Hi, I want to welcome you to our Facebook chat today. I'm Dr. Ralph Dauterive with Ochsner of Baton Rouge. I'm a board certified gynecologist. I've been in practice with Ochsner and in Baton Rouge since 1987. I specialize now in gynecologic surgery and minimally invasive gynecologic surgery. And I'm here today with one of my colleagues from a long time, Dr. Michael Perniciaro. Good afternoon, Dr. Perniciaro.
Thank you, Ralph.
Why don't you go into traditional and laparoscopic surgery and how things moved through in our career?
When I first started, basically with either abdominal hysterectomy or vaginal hysterectomy. There was no laparoscopic assisted. There was no robotic assisted. This back in '86, ladies would come in, spend 3 and 4 nights in the hospital. Big recovery time, and halfway through my career, the laparoscope became very popular, and we started doing laparoscopic hysterectomies. And then even further down into my career, we began with robotic hysterectomies. And I've been doing robotic hysterectomies now for 10 years, but I would say they've been doing them at Women's Hospital for more like 15 years. So it's evolved from 5-day stay in the hospital all the way down to 5 or 6 hour stay now in the hospital. And that's been a dramatic improvement.
Yeah, I agree. The cases I did this morning are already gone from the hospital. I did 2 robotic cases before I came over, and they're discharged now. We had the same experience. We were very aggressive, minimally invasive surgeons. We were trained very aggressively as vaginal surgeons in residency. And yet our abdominal hysterectomy rate in the mid 2004, we calculated out at about 35 to 36% on a national average of about 60%. So we were more into minimally invasive surgery with straight laparoscopic hysterectomies and vaginal hysterectomies than the rest of the country was. The robot offered us an opportunity to take it to another level and to do other surgeries with it. So in 2006, we got an opportunity to get a robot in Baton Rouge at the hospital on O'Neill Lane. And Dr. Thomas Payne and I trained and made a decision to try and do as many robotic cases as we could. And then we went back and recorded our experience and wrote an article that I actually saw got cited again in somebody's review of robotic surgery. It was a kind of interesting little article where we had a 96% minimally invasive surgery rate in the first 100 cases and a 98% minimally invasive surgery rate in the first 200 cases. So we really thought we were onto something that would allow even more women to not have to have an abdominal hysterectomy. And really have stuck with that. And the group has been able to keep their minimally invasive surgery rate above 96% in spite of bringing in new partners and with different levels of experience. So definitely the robot offered surgeons the capability to take their minimally invasive skills even further because they could comfortably do these cases without an open incision. Is that your experience as well, Mike?
Definitely. And another thing that brought me to robotics, I was a late convert. I thought, it can't be any better than just straight laparoscopic hysterectomies. And I would make rounds on the weekend for my for my partners. And I would walk into the room and the ladies were already dressed and ready to go home, having hardly minimal pain whatsoever. And I'm like, I just can't believe there was that much less pain from the robotic hysterectomy than from the laparoscopic hysterectomy, but it made me a believer. And then I became trained in robotics, and it's been really wonderful for my patients. They less pain, less time out of work. It's been really wonderful for them.
Yeah, I'm actually always amazed I'll have patients come in and tell me they never opened the narcotic prescription. And they just use ibuprofen and Tylenol, and which is really important because gynecologic surgeons have been targeted as one of the groups that gets people addicted to narcotics with some of these events. So it's nice to be able to really not have to use narcotics in this. Mike, what would you say, what do you think the difference between straight laparoscopic and robotic is? What makes it better for the patient? I know it's better for the physician because my back doesn't hurt nearly as much when I'm doing the case. Why is it better for the patient?
I seem to think it's less manipulation and less retractions and things like. And I also find that we're able to do more surgeries on larger uteruses that you would not be able to do laparoscopically. People with adhesions that you aren't able to do with the straight laparoscope, and it is increased. I know my success rate of not having a laparotomy incision.
Oh yeah, I agree. I don't know if you've had one of these experiences. I had a physician send me a patient that he tried to get a left ovary out with straight laparoscopic technique, and he stopped, he bailed, and sent her to me because he didn't have access to a robot. And I took it back to surgery, put the robot in, and with 20 minutes, we were able to get the left ovary out. And it was just because we had more confidence, better visibility, three-dimensional view, and the ability to manipulate that colon away with knowing that we weren't getting into it. And when I used to give talks on robotic surgery, I would cite that case all the time because I would tell the people that you're going to have a case like this, that you would have said, I'd had to open this patient and to do that. The big uterus is another real advantage. I've definitely put I've taken people for robotic hysterectomies with big uteruses that I would never have done with straight laparoscopic. I wouldn't have even tried. And you're able to do it. I mean, it's pretty interesting.
Yeah, I would say if not routinely, we would wind up having to open someone from a laparoscopic approach because we weren't successful. But it's extremely rare that we ever convert from a robot to a laparotomy incision. So, I mean, the success rate of minimally invasive is so much higher with the robot.
Yeah, and when we did the original study, we didn't really look at conversion rate. And I think that the conversion rate is misleading because people they see a big uterus or a tough case and they just wouldn't try it laparoscopically, whereas robotically they will. So I always measure the overall minimally invasive surgery rate in the practice. How many cases are you doing vaginally and robotically as opposed to abdominally? And that is always my measure of success of a robotic program or a minimally invasive surgery program. And I think you can take it above 95%. It can really go there and really eliminate all of these incisions and time away and pain, et cetera.
And it's just remarkable when you talk. Go ahead.
Go ahead, Mike. I'll make your point. I was going to move number three.
It's just remarkable to me that how quickly patients go back to work and the decreased amount of pain level. And I find the same thing as you. Most people don't even get their narcotic prescription filled. They are fine with ibuprofen.
So when you do a robotic case, why don't you walk us through sort of from the patient's perspective, what happens when they're asleep, so that they'll kind of get a feel of what goes on in these minimally invasive cases.
Well, we got that pre-op visit. We go over the procedure because most people come in and they like, well, I don't want the robot to do my surgery. I want you to do my surgery. And you have to explain to them that the robot is an instrument. It's just like a laparoscope on steroids. It's and you're doing the hysterectomy. It's not a robot doing the hysterectomy. It's just an instrument. But we'll talk to them about they come into the operating room. They get placed under anesthesia. We place our 4 trocars for insertion in the other arms of the robot, and they basically do fine. And before you know it, it seems like they're in the recovery room and on their way to recovery.
Yeah, I think that's my approach. Manipulator. We use a co-cannula around the cervix to allow for visual access and feeling of the vaginal area through the abdomen. And I do a 4 trocar technique now with the Da Vinci Xi. That's the latest one. I think Woman's has that, and we do as well.
Correct.
So much easier to dock than the original one. I with the original robot, I always felt like I was backing up a tractor to a plow because it had to be perfect. And we used to talk kid about that all the time. But the new robot allows for very unique docking from the side, from any position you want, really. And the 4 trocar technique for me, I converted to it when I started taking out more fallopian tubes because it gives me the ability to just do everything without even almost not having an assistant at the bedside except to manipulate. Um, Surgeries, it depends upon the uterine size. People always want to know how long it's going to take. Um, I've seen my colleagues do 22-minute robotic time on and getting the uterus out. But then again, I've seen big uteruses take 2 hours. It really is anatomical based. But the average robot's usually taking us around an hour by the time we put the patient to sleep and get everything ready to go. Is that your experience?
That's been our experience. It's an hour. That I tell the patients it's going to be an hour to let their family know that that's about how long it'll last. And again, same as you.
Absolutely. And
Years take a little longer.
right. I do let the patients know that it's after I get everything set up, I will be sitting down at the console and not right by them. I get comfortable and take my shoes off so that I can feel the pedals, like playing an organ is what I usually tell people it's going to be like. And off we go and rolling along. Mike, what type of surgeries are you performing with robotic and laparoscopic now?
Mainly the robotic surgeries are the hysterectomies. Last week I did a oophorectomy on a patient. She requested robot as opposed to laparoscope because all of her friends had robot and had basically painless surgery. And she obviously had painless surgery, and it was amazing how much easier it was to take her ovaries out with the robot than it is with the straight laparoscope. Because as you said, you have the 3 dimensions, much easier manipulation. You can move the colon out the way. You can work better with adhesions. So basically, though, the vast majority of the robotic surgeries we're doing are hysterectomies. Is that
and I've had that. That's my experience. If I'm going just after an ovary, if it's a previous hysterectomy patient, and I think especially if the ovary I need to go after is on the left side, where it could be buried by the colon, and I may have a little more bowel retraction to do, I generally push. I push to go with the robot at that point because I know I'm going to be able to get that left ovary out. Or if I read an operative note that talks about significant adhesions in the pelvis, I'm pretty quick to do ovarian surgery with the robot. I've done a fair number of endometriosis cases with the robot. There was some articles written a couple of years ago about the advantages of the robot in visualization of the ureter, resection of deep endometriosis implants, and then it's a very nice tool for resecting endometriosis out of the ovary if you're really trying to preserve ovarian function. So I've done it. I've used the robot for that. And then for vaginal prolapse cases, I started doing robotic colposacropexies to replace my laparoscopic colposacropexies, which were very difficult to do. But the robotic case is a very nice case for that. Generally an older patient, and they get up and walk out the next morning. It's pretty amazing how well those patients do with cuff prolapse. And then the other case that I've done is I've done some urinary incontinence surgeries, the Birch cystourethropexies. I've done robotically, and I'd been doing that laparoscopically in the years leading up to that, and I was almost ready to quit doing it laparoscopically because it was so difficult. But once we got the robot, we started doing it as well, and probably did our first one in about 2008. We did the first Birch procedures here, and Dr. Payne and I used to do some. Now I'm pretty much the one in my group that does the robotic Birch. Nice success with those cases. I've done most of those at the time of hysterectomy if a patient has stress incontinence. But I have taken a few people in who have failed a transoperative tape procedure or some sort of sling and are candidates for a Birch. The laparoscopic Birch is a very nice procedure to do. It's actually easier than an open Birch because you can see the anatomy a lot better.
Visualization is right. The anatomy and visualization is so much better.
Yes. You do have to have an assistant that trusts you to drop the suture across the finger that they happen to place in the vagina when you're doing the case. Because in traditional surgery, that's your finger. But in the robotic case, it has to be your trusted assistant's finger. My assistant has always told me that the day I stick her is the last day she does that, but I haven't stuck her yet. So she keeps operating with me. My daughter, the doctor, did one case with me like that, where she had to be the assistant, and she kept moving her finger every time she'd see the needle come close. She would pull her finger out, and she felt like she had failed me. I told her that was okay. She's been a good daughter. So
she didn't trust
definitely. Yeah, she trusted me. We talked about the advantages to the patients. Mike, in your review of the literature and watching robotics develop, how are you impressed with safety and quality that made you be a convert?
The visualization is just amazing. I mean, you can identify the ureter so much easier than you can on an open case, and then definitely on a laparoscopic case. Just the extra manipulation in the 3D visualization is definitely contributes to increased safety for the patient, and we've done well.
Yeah, I agree. From an infection perspective, it's definitely a low infection rate procedure. Blood loss, I tell patients sometimes I'm almost embarrassed to say how little blood we lost. I don't want people to think I'm lying when I say we lost 5 or 6 cc's of blood, but you can get these cases pretty bloodless. And you'd lose that much blood with an abdominal incision and in the best surgeons. And so, and then the ureter visualization is outstanding. And that was from the beginning, the 3D visualization of the pelvis. I think it is better than an open case because you can't put your eye right inside the pelvis when you're open.
Right.
You can only do it when you have a laparoscope. I was always amazed by the 3D vision when we first started these cases and that capability. So we talked about recovery time and different conditions that are treated. Anybody in your group doing any other robotic type procedures that are different, unique, experimental?
I think they're all doing the basics, the same, everything that I don't think anyone's doing any of the urology cases, but they're doing the oophorectomies, they're doing endometriosis, we're doing the hysterectomies, and they seem to be doing well.
No one ever really asked me to come and teach them the Birch procedure when we were doing a lot of teaching with Intuitive. But when the scare with the graft material, when the FDA pulled some of the bigger graft material from the market that people were using vaginally for these prolapse cases, this group up in Tennessee, in Jackson, Tennessee, asked me to come up and teach them how to do the Birch, and they just loved it. It's a nice procedure. So if you have patients that are looking to have a different type of stress incontinence surgery, it's a nice approach for that. And they recover beautifully. I mean, my patients don't wear a catheter when they get the catheter removed. They do very well with that procedure. So nice time. I think the other thing that we should mention is, the United States generally has a little bit of an obesity epidemic going on. And we do wind up, especially fibroid patients tend to be a little overweight sometimes. And what's your experience in the advantages with the robot in the obese patients?
Oh, definitely decrease in their infection rate. They're getting up and moving quicker. Therefore, it's going to decrease their risk of blood clots and DVTs. How soon do you tell your patients to allow your patients to go back to work, Ralph?
I've had nurses go back to work in 2 weeks. Some of the administrative nurses, not the ones that are actually lifting patients. So I've let people during the COVID pandemic go back to Zooming in a week or less, whenever they really wanted to start back. But I tell people about 2 weeks. I tell people that they can drive when they're not having any pain, because I don't want to add to the traffic problems in Baton Rouge that we already have with people running into the back of people. But generally 2 weeks, all my patients drive themselves to their 4-week visit. And then I let them walk and start participating in light exercise after 1 to 2 weeks, as long as they're comfortable with it. And I tell them no heavy lifting and heavy workouts until 6 weeks. And, I've extended the time that I recommend people avoid having vaginal intercourse. And I've pushed that back to 12 weeks now. I've just had some concerns about the vaginal cuffs healing up during these cases. I think it has a lot to do with coming across the cuff with the electric cautery and the tissue not healing as well as I wanted to. So I pushed back to 12 weeks for intercourse. What about you guys?
It's just about the same. I have a patient called me last week. She said she was in a lot more pain than she was when she went home. She had her hysterectomy on Friday. She went back to work on Tuesday. And that was the explanation for her pain. But it's basically 2 weeks for most people who aren't doing any real physical labor at work, lifting patients, working at a plant, things like that. But after 2 weeks, they can go back if they have a desk job. I'm like you. I tell them, no driving for a week or so until you're not taking any pain medicine that are narcotics. And we've stuck with the 6 week for intercourse, but it does make sense to give it a little longer there. And I'm like you, no exercising or working out for the first six weeks, but I'll let them start walking after 2 weeks if they're ready to get back on the treadmill and walking in the neighborhood. It's just amazing from when I first started, how long ladies took to recover from their surgeries and how long they take to recover now. And it's all related to the big incision.
Yeah, I remember doing vaginal hysterectomies with John Holland. I don't know if you remember Dr. Holland at Ochsner. He was a brilliant surgeon. And we would do the cases on a Friday, and he would say, take care of them over the weekend, boys. I'll see you Monday. And that would be the typical, 2-night stay or 3-night stay for a vaginal hysterectomy. And you started to see through the 90s, the health plans were pushing you on length of stay. But at the same time, we were getting much more aggressive with the use of the nonsteroidal anti-inflammatory agents. We used a lot of Toradol in the 90s post-operatively, and that made a huge jump in the length of stay. I think it cut it in half. And then you started to do even more minimally invasive surgery. And now between the minimally invasive surgery techniques and the way we prep the patients in that perioperative setting, you're starting to be able to let patients go home sooner. And some of that is earlier return of bowel function because you're not in there with your hands, for sure. but it's also the anti-inflammatory drugs that we have access to. My pre-op for laparoscopic and robotic hysterectomies now, my patients drink apple juice 2 hours before they come in for their surgery. We give them 1,000 milligrams of oral Tylenol right before they get put to sleep, and then they'll get some sort of non-steroidal in that perioperative period. And there's less narcotic use, so there's less nausea. There's quicker return of bowel function because you've given them some stuff. And the apple juice in the morning has been proven to keep that blood sugar pretty level through that fasting period, which effectively starts about 9 o'clock the night before. And when you look at a case that might be second or third case, you're looking at 3 o'clock in the afternoon before people are getting to drink or get some glucose back in them. So that whole combination of things, along with the robotic capabilities, really allows people to hop out of the hospital in a couple of hours, like you said. 3 days to 3 hours. It's pretty amazing.
Absolutely.
So they have some common patient questions here. Why don't we go through these? So everybody always hears the good news and the bad news about procedures. What would you tell someone who's fearful of robotic surgery or even laparoscopic surgery and just wants it done the way their grandmother had it done?
Well, I basically just explain the procedure to them. I truly, what I was talking about before, they really don't feel like you're doing their surgery. And when you explain to them that it's just an instrument, that alleviates a lot of their concerns. I find the more you educate the patient, just walk through the procedure. You're going to go into the operating room. I'm going to be standing next to you. They're going to put you to sleep. We're going to do this. We're going to do that. After this, you go into the recovery room. I think that really alleviates a lot of their concerns they have about having any kind of surgery.
I agree. We answered a couple of these other questions already. Can a patient walk after the procedure? For the most part, they can walk when they recover from the anesthesia. Has been my experience. I generally tell patients, take it easy the first day because you're still under the influence of the anesthetic. But once they can walk, we want them to walk because we want to take that deep vein thrombosis rate down to almost zero, and we want them taking nice deep breaths. Has that been your experience as well, Mike?
It has. Also, too, when I first started doing the robotic surgery, I left their catheter into the next day. I wasn't a big proponent of sending someone home the same day of surgery, but I've gotten comfortable with it over the years. And the catheter comes out in the recovery room. They're up and walking, and definitely encourage them to get up and walk.
Yeah, I started pushing that envelope on that catheter, and I kept asking myself, why am I leaving this catheter in for the night? And then we would take it out first thing in the morning, and then we progressed to taking it out on the floor when the patient could walk around a little bit. Then we moved to the recovery room. And then some of my partners started taking the catheter out in the operating room when they would finish the case.
I have partners that do that also. As soon as the case is over, the catheter comes out before they even make it back to the recovery room.
Yeah, and the reason that I hesitate on that one is that I want the patient to be able to tell the recovery room that their bladder's full or not, and so I want them awake after we pull the catheter, or just awake enough. So that I went back to when they're ready to leave that recovery room phase, that's when I want the catheter pulled. Because my concern is that the bladder would fill and they're still sedated, and we would be having a patient with pain and we wouldn't be able to know why. That being said, my partners have done it like your partners have, and they haven't had any problem with it. So we change over time. We try things differently all the time, and when something works, you move toward it. Otherwise nothing ever gets changed.
I think that's the same experience that we're having here.
I like this next patient telling people to sleep a certain way after surgery. Um, I don't recall ever worrying about that. Do you have a
No,
do you
I
have a
tell them
concern
sleep
about that?
any position that you're comfortable in.
Yeah, it's not orthopedic surgery and it's not back surgery. The pelvis generally is okay no matter what position you sleep in, and they're not pregnant, obviously, so they don't have to sleep on their side. So any position's fine. Um, we went over resuming activities, and the next question I think is interesting for any surgery. What do you do after surgery? How, MRSA is a big deal in all of our hospital settings, and we're all fighting to keep it away and under control. Do y'all have any special protocols to keep that incision from getting infected, even though the little robotic incisions, if they do get infected, are really not that big a deal? It's almost like a
No,
pimple if it gets infected.
we don't have any special procedures. Do you allow your patients to shower?
I do. We dermabond. We put we put subcuticular sutures in because we found that just dermabond wasn't enough. Sometimes these little incisions ooze from a little fat vessel, and the dermabond would break and open all the time. So we do a subcuticular incision, which goes away on its own. Nobody has to get their sutures removed, and then we dermabond it. So I'm very comfortable with letting them shower after 24 hours. And the only reason I don't let them shower the day of the surgery is just, again, I'm worried about the anesthetic effect and them getting the weak and dizzies in the shower. And so I tell them the next day that they're welcome to take a shower. We've cleaned that abdomen really well that night, that day of surgery. The only other thing we do a nasal swab with a product called Nosen, which is basically alcohol that's been treated with this orange stuff so it doesn't burn so much when it goes in your nose. And we start the Nosen pre-op, and then the patients do it twice a day for about 2 weeks. Uh, there have been some studies to show that makes a difference. It's part of our cesarean section and preventing a cesarean section infection rate. And we did see a significant drop in the C-section infection rate, but there was lots of other things we did besides the nose, and we did some other things along the way. But it's more of a hospital-wide, it's a surgery-wide event at Ochsner at Baton Rouge. It's not done at all the Ochsner hospitals. Some places use a different type of, they look like an antibiotic. There's the little antibiotic that you put in your nose to prevent infections as well. But we've used Nosen to do that. That's the only thing I think do that's a little different from other people. I know in my practice, and you talk about what you've heard over the years. You see people who need a hysterectomy because of their bleeding or their pain, and as a gynecologic surgeon, you just know that's going to make them better. And there's that major hesitation. What's your experience and what causes that? I mean, why are people afraid of that hysterectomy?
Well, I think they're afraid it's going to change their bodies. They're going to change their feelings. They're going to change uh, their pleasures with sex. They're afraid they're going to have hot flashes. A lot of people, aren't aware that if you keep your ovaries, it's not going to really affect your hormones. So I think if you educate them again, let them know what's going on, explain everything you're going to do, I think that helps tremendously with all these myths that they've had. The biggest myth, I think, was, am I going to gain weight? I must hear that every other person who's scheduled for hysterectomy, and you address that issue. But it's all handed down and from family members to family members. But education is just really important.
Mike, were y'all ever doing supracervical hysterectomies with the laparoscope, or did you always approach it as a total laparoscope, a total hysterectomy?
Our basic approach has always been a total hysterectomy.
And that goes back to the old straight laparoscopic hysterectomies when people were first starting to learn them. It took a little bit of extra skill to take the cervix. It was the part that threw people off, and suturing the vaginal cuff back closed was a talent that you really had to learn. It was very, very difficult, I thought. And that's why people would start laparoscopically and then finish vaginally. But some people just did supracervical hysterectomies to avoid having to do that part of the surgery. I personally haven't found with the robot, I just don't feel that it's that much more difficult to take the cervix. What's your experience there?
I think with the dexterity you have with the three-dimensional on the robot, it is much easier to suture the cuff than even suturing the cuff vaginally. So that's been my experience.
I agree. When we were doing laparoscopic assisted vaginal hysterectomies, which was sort of our first venture into it, because we couldn't figure out a way to suture the cuff, a lot of times the hardest part of the surgery was suturing the cuff through the vagina, because if they didn't have any prolapse, you got yourself in a situation where you were working, 8-9 centimeters up in a cavity. And we found a little instrument that allowed us to do that. But even that instrument was a very interesting instrument. The only reason we really liked it because it could go down a 5-millimeter port and keep our port sizes really small. But it was called the Suture Assist, and that was an amazingly, you had to have some dexterity to pull that puppy off. It was tough. There was like a 1-millimeter loop that you had to pass the needle through down in the pelvis, with basically straight sticks. And so it was one of the biggest advantages in time of spent doing the hysterectomy that we gained was in suturing. When comparing to our straight laparoscopic time, we picked up most of our gain in the suturing of the cuff, and we probably cut half the time off doing it just by converting with that product. So,
and then even further now with the sutures that even further now, when we first started doing the robotic hysterectomies, you had to tie each suture separately, and it was a clip that you put on the suture to close it. That time has all been eliminated now that you have the running suture.
Yeah, absolutely. And it is, tying knots with laparoscopes is still interesting, but the robot does make it a lot easier. If you have to do surgeries that require suturing, it brings the minimally invasive concept back into the pelvis, because you can suture so easily in the pelvis with the robot. So the final things are how robotic laparoscopy has changed gynecologic surgery. You've seen it all. You and I are old enough to have watched this. In our career, we've seen some pretty significant advances in surgery. What would you say the changes in gynecologic surgery have been now?
I think so many of the changes are related to instruments that we use. When we first started in ectopic pregnancies, we didn't have all the ligatures and the instruments that made it so quicker to perform surgery and so specific for what you needed. And the length of surgery has been drastically reduced with the improvement in the instruments that we use for surgery. And again, the amount of time you spend in the operating room, the amount of time you spend in the hospital, the amount of time you spend off from work, that's been the biggest change in surgery, is basically the time that you're out, the time you're on the operating table.
I would agree. I think that's the advantage for the patient, absolute. The advantage to the healthcare system is we don't have as many people in hospital beds. And that actually rolls over into an advantage for the patient, because they're less likely to get an infection from being in the hospital, which we know is real. And being able to get people up and around and eating decreases the risk of some of these respiratory, urinary, and vascular problems that you run into in pelvic surgery, for sure. And I think it's also, it's opened up, if you look at gynecologic cancer surgery, and you and I are not gynecologic cancer surgeons, but the cancer surgeons really adopted these surgeries dramatically, and they're able to do node dissections and, omental resections. I remember doing some of the first robotic cases with Dr. Fort as we were training him on robotic surgery, and he just looked at us and said, "You've added 10 years to my career," because he was getting tired of standing next to the bedside. His neck was starting to hurt, and that's generally what's happening to old surgeons. Uh, and I would agree. I think when I have to stand up next to the bed in a traditional laparoscopic surgery, it's tiring. And you don't want a tired surgeon. You'd rather have a fresh surgeon that's not worrying about their neck hurting or their knees hurting and stuff like that. And the robot allows the surgeon to sit in a very comfortable position to do extensive surgery if they need to. And I think that's made a huge difference in keeping more people having minimally invasive pelvic surgery for sure. Okay. You think they know how to get in touch with us, Mike?
They can get in touch with us through either Ochsner's website or Louisiana Women's website here in Baton Rouge. We're easy to find.
Yeah, and I think if they're looking for a surgeon that does minimally invasive surgery, we have groups that are at the cutting edge of this, and our groups are big proponents of minimally invasive surgery. I think the people of Southeast Louisiana are very fortunate. There's plenty of robots that we've brought in, and we've trained a lot of surgeons in how to do minimally invasive surgery. Mike, I would ask you one interesting question. I've had friends, and people know what I do for a living, and when you hear that someone's about to have an abdominal hysterectomy, and someone asks you, like they do, what do you think? What do you do? What is your response to that?
Tell them, have you looked into your other options? And ask them why they have their hysterectomy. Get a little bit of their history of previous surgeries and that. And that's where you might really want to talk with your doctor and see if there's a different approach you can do. And I explained to them, you will be recover quicker, your pain will be better, your back to work is so much shorter time. And a lot of them have gone back to their doctors and have decided to have the the robotic assisted hysterectomy as opposed to their straight total abdominal hysterectomy.
Yeah,
have you found that?
Yeah, well, at Chalmette High School, they taught us to be very direct and not to hold our tongue, I think. And so I think we both have. I have a hard time not informing people of what's available, and people trust their physicians. They have a relationship with the physicians, but I believe enough in minimally invasive surgery, and I know that people can get into the 96 to 100% rate if they are trained and they try, and then it's the better procedure for the patient. So if asked, I do advise that they consider a minimally invasive surgery and make sure that their surgeon addresses it and don't just default to the abdominal hysterectomy, which which I don't think is in their best interest. And sometimes you find that they have a condition that even I would have done an abdominal hysterectomy on,
Right.
and you can reassure them that they're doing the right thing. But I know through the early phases of this adoption, we had surgeons around, and probably still have some pockets of this where people just have not adopted the new surgeries. One of the things I tell people all the time, would you have an open cholecystectomy? And I mean, when's the last time you ever heard of someone having an open cholecystectomy? And well, when you and I came out, those big incisions for gallbladder operations were very common. And you don't see that on young patients anymore. You just don't see it. And that took some significant transition to get the surgeons moving in that laparoscopic direction to do that. Gynecologists have always sort of been on the cutting edge of minimally invasive surgery because we were vaginal surgeons as well. And I think the field is definitely moving in that direction. So I generally politely push them to consider a minimally invasive surgery technique for sure. You think we covered everything?
I think so. I want to thank everyone for tuning in. And it was nice seeing you again. I'm sure we'll be running to each other soon here in town.
Absolutely. I mean, when I was on staff at Woman's, one of the pleasures I had of going to Woman's Hospital was running across my old friend, Dr. Perniciaro, and catching up on what he was up to. We would talk LSU football and basketball and baseball and old times. Because after Katrina, we talked about all our relatives that had to move to Baton Rouge. I know you housed a couple of hundred people at your house a couple of times, and I did too. And yeah, I miss seeing you. So it'll be nice. I think we're going to see each other this week at a little open house. So that'll be fun.
We are.
So to find one of our minimally invasive gynecologic surgeons in our groups, the Ochsner group has 6 minimally invasive gynecologic surgeons. We can be found at the ochsner.org website specific to Baton Rouge. And we welcome you to go to that site and look us up. All of our surgeons do perform minimally invasive and robotic surgery. And Dr. Perniciaro, how do we get in touch with the members of your team?
We're located at Women's Hospital. You can locate any one of our 33 physicians at lwha.com. Thank you, Ralph.
You bet, Mike.